In the perioperative intensive care unit, metabolic acidosis is a frequent and severe complication. Up to 40% of acute metabolic acidosis cases in this setting present specifically as normal anion gap metabolic acidosis, or NAGMA. To diagnose the underlying cause, we typically calculate the anion gap. This calculation relies on the principle of electroneutrality. In a healthy physiological state, the total positive charge from measured cations, like sodium and potassium, equals the total negative charge from measured anions, namely chloride and bicarbonate, plus a small pool of unmeasured anions. The standard formula presumes the pool of unmeasured anions remains at a normal baseline. The majority of this charge comes from plasma albuminate. However, critically ill perioperative patients rarely have normal albumin levels. Severe hypoalbuminemia is a near-universal condition in this population due to systemic inflammation, malnutrition, and fluid shifts, overturning the assumptions of the standard baseline. When plasma albuminate is depleted, negatively charged proteins are physically removed from the serum. Because these proteins usually make up the bulk of the unmeasured anion pool, their absence artificially shrinks the baseline anion gap. This chart illustrates the danger. Focus on the left panel, the measured anion gap readout. Depleted albumin lowers the negative charge, creating a physiological mask. Lethal organic acids like lactate fill the void. The gap appears normal, keeping the true pathology completely hidden. Relying on an uncorrected anion gap in the ICU provides a false sense of security. It leads clinicians to misdiagnose the severity of the illness, allowing severe occult metabolic acidemia to progress undetected. To strip away the hypoalbuminemia mask, we must adjust our diagnostics. Calculating the albumin-corrected anion gap, or ACAG, is a mandatory step for patients in the ICU. This formula applies a Henderson-Hasselbalch correction for albumin depletion. We take the measured anion gap and add a specific correction factor. We calculate the difference between a normal albumin level of 40 and the patient's actual albumin, multiplying by 0.25. That coefficient accounts for the missing negative charge of the lost albumin proteins. By adjusting for this loss, the formula shifts the physiological baseline back to reality. What initially presented as a falsely normal gap recalculates into a severely elevated corrected gap. Looking at the right panel, we see the effect of the ACAG correction. The transparent blue box reveals the true underlying high anion gap metabolic acidosis. A corrected gap over 12 millimoles per liter proves unmeasured plasma acids replaced the lost albuminate. Applying this mathematical correction abruptly unmasks a range of dangerous compounds. We can now detect endogenous organic acids like lactate, acetoacetate, and beta-hydroxybutyrate, as well as exogenous toxins like salicylates, methanol, and ethylene glycol. Computing the albumin-corrected anion gap is a required clinical maneuver. Without it, the risk of a lethal misdiagnosis is unacceptably high. Even with albumin correction, the Henderson-Hasselbalch model has limits. It often fails to explain the complex, iatrogenic acid-base states frequently induced during surgery and critical care. For these complex scenarios, we turn to the Stewart method. This is the physical-chemical model required to uncover hidden and mixed acid-base disorders in the ICU. This matrix compares the two assessment models. Henderson-Hasselbalch relies on bicarbonate and PCO2. The Stewart method uses strong ion difference, total weak acids, and PCO2. Under perioperative utility, electrical neutrality is respected. Variation in bicarbonate is a passive consequence, not its primary cause. We can apply Stewart's model to a universal intensive care scenario, treating shock with massive fluid resuscitation using 0.9% normal saline. Normal saline contains equal parts sodium and chloride. A massive saline infusion introduces a disproportionate chloride load, which mathematically forces a rapid reduction in the strong ion difference. To maintain strict electroneutrality, water molecules dissociate, releasing a proportional increase in free hydrogen ions. This physicochemical reaction creates a severe hyperchloremic acidosis. It operates entirely independently of any gastrointestinal or renal bicarbonate loss. By adopting the Stewart method, clinicians avoid mistaking this dilutional hyperchloremia for organic acid accumulation. This understanding averts inappropriate and potentially harmful clinical interventions. In practice, critical care patients often present with mixed metabolic states, where high anion gap and normal anion gap acidosis coexist simultaneously, confounding the primary diagnosis. The recovery phase of diabetic ketoacidosis, or DKA, is the archetypal shifting, mixed pathology encountered by perioperative physicians. DKA initially presents as a classic high anion gap metabolic acidosis due to the massive accumulation of ketone bodies. But as the patient receives fluids and intravenous insulin, physiological recovery initiates a complex, highly dynamic transitional phase. Ideally, as insulin takes effect, the accumulated ketoacids are metabolized to form fresh bicarbonate. However, the kidneys simultaneously excrete significant quantities of unmetabolized ketoacids into the urine. This urinary excretion represents a permanent loss of potential bicarbonate. When combined with the chloride load from saline resuscitation, the patient transitions directly into a normal anion gap metabolic acidosis. This checklist section displays the quantitative tool required to isolate and track these concurrent mixed disorders, the delta ratio. The formula divides the change in the anion gap by the change in the bicarbonate concentration. Evaluating the ratio allows us to distinguish between a pure hagma, a pure nagma, or a mixed state. A ratio near 1 indicates a pure high anion gap process. A ratio significantly below 1 confirms a concurrent normal gap acidosis. Mastering the delta ratio provides exact quantitative precision. It enables clinicians to track true pathology resolution rather than being misled by mere physiological compensation. The utility of the anion gap extends beyond diagnostics into precise prognostic stratification. We find a direct correlation between corrected anion gaps and patient survival. An elevated ACAG is an independent, validated predictor of perioperative and intensive care mortality. This multi-line hazard ratio plot shows the data clearly. Survival curves diverge based on gap measurements. If the patient's albumin-corrected anion gap crosses the threshold of 12.76 milliequivalents per liter, the survival curve drops steeply, separating completely from normal baselines. This risk is especially pronounced in vulnerable cohorts. Patients with chronic kidney disease who present with a baseline ACAG elevation face a 22% increase in all-cause mortality risk. Mediation analysis reveals the underlying pathophysiological drivers of this mortality spike. A significant portion is linked directly to concurrent systemic inflammation, marked by elevated C-reactive protein levels. The remaining mortality risk is mediated by compromised renal clearance, specifically a progressively reduced estimated glomerular filtration rate. Grave ACAG must be treated as a critical red flag signaling imminent, multi-system physiological failure. With the diagnosis and prognosis established, strict adherence to these algorithms must drive targeted, high-risk therapeutic interventions. The current gold standard for managing severe metabolic acidemia in critically ill patients is provided by the formalized guidelines from the French Intensive Care Society. These guidelines address the ongoing clinical controversies surrounding intravenous sodium bicarbonate infusion. Administering base therapy carries inherent hemodynamic risks, including hypokalemia, hypernatremia, volume overload, and rebound alkalemia. Look at point 6 on this perioperative acid-base checklist. Because of the risks, the physiological threshold for initiating intravenous sodium bicarbonate is strict. It is heavily restricted to patients presenting with severe acidemia, defined by an arterial pH less than or equal to 7.20. There is also a mandatory secondary requirement for base therapy. The patient must concurrently present with moderate to severe acute kidney injury to justify the hemodynamic risk. For refractory metabolic acidosis that fails to respond, we must transition to the ultimate interventional escalation, the immediate initiation of renal replacement therapy. The precise evidence-based trigger for renal replacement therapy is an arterial pH dropping below or equal to 7.15 in states of shock, regardless of standard KDIGO severity criteria. The mechanical rationale is straightforward. When endogenous physiological buffering has scaled entirely, renal replacement therapy forcefully clears unmeasured organic anions from the blood and physically corrects the strong ion difference. The complete perioperative workflow sequence requires discipline: validate the severity of the acidemia, calculate the standard gap, mandate an albumin correction, evaluate complex cases via the Stewart and Winters formulas, isolate mixed states with the delta ratio, and finally, triage for targeted interventions. Mastering this rigorous physicochemical logic makes the anion gap a precision instrument for ensuring perioperative survival.